So good morning everyone. I'm presenting on behalf of Medicine 2 on the topic surplus sugars. Uh, Presenting a 53-year-old female, Mrs. S from Chhattisgarh, who presented to our ED with complaints of progressive loss of weight and appetite for the last 6 months, shortness of breath for the last 3 months, and frothy urine for the last 3 months, which was associated with swelling of legs and burning sensation over both feet for the last 3 months. Coming to the history of presenting illness, she developed chronic exertional breathlessness, which was progressive in nature over the last 3 to 4 months. And over the last 1 month, she has been having orthopnea and PND. And she also complains of giddiness on getting up from supine position. She also complained of passing frothy urine, and she also noticed progressive swelling of her body. It started in her legs and then went on to progress to involve around the eyes and also the hands. She also had complaint of on and off non-bloody watery loose stools for the last 3 months. And the negative history, she didn't have any symptoms suggestive of connective tissue disease. There was no chest pain, cough, of syncope. She did not complain of any burning micturition, hematuria, or any reduced urine output. She never had jaundice and basic malignancy screen. She did not have any history suggestive of an underlying malignancy except for the altered bowel habits. She did not give any history of any motor weakness or any sensory disturbances except for the bowel bladder disturbances. Past history wise, she was on dual antiplatelets and statins, which was prescribed outside. She was said to have some ischemic heart disease. And for the burning sensation, she was diagnosed with some peripheral neuropathy, for which she was on gabapentin and B12 supplements. She never had diabetes, hypertension, or any thyroid disease previously, and no previous surgeries. She did not have any family history of malignancies or any connective tissue disease. So on examination, she had a blood pressure of 90-60 millimeters of mercury, which on standing at 1 minute and 3 minutes became 80-40 millimeters of mercury. The pulse rate was 98 per minute. She didn't have any compensatory tachycardia. Her respiratory rate was 22 per minute, and the saturation was normal, and JVP was elevated. She had pallor and anasarca at presentation. There was no significant lymphadenopathy. Systemic examination wise, CVS S1 and S2 were heard. No murmurs were there. Respiratory system, she had bilateral reduced air entry in the intrascapular regions. Abdomen was soft, and there was dullness in the trough space, and there was no focal neurological deficit. Examination of the skin showed some dry atrophic skin with absent hair, and ankle jerk was absent bilaterally. And local examination wise, she had some purpuric spots over her hands and also prominent tooth markings in the lateral aspect of the tongue. There was no peripheral nerve thickening. Power was normal in the proximal and distal aspects. And this is her ECG. What we could observe from the ECG was that there were Q waves in the anterior limb leads V1, V2, and V3, and there was globally there was low voltage complexes throughout the limb as well as chest leads. And this was the bedside echo that we did for her. And what is the clinical diagnosis? It's a patient with constitutional symptoms of weight loss, loss of appetite, and progressive exertional breathlessness, and some frothy urine. We thought of nephrotic syndrome or any chronic decompensated heart failure initially, sir.
So, nephrotic syndrome, but there are other symptoms. There was an elevated JVP,
yes,
absent sensations, absent ankle jerk, purpuric spots on the limbs.
Some peripheral neuropathy, some sense. Yes, sir. Some disease, multisystemic disease we were thinking of.
Provide a clinical diagnosis.
And this was the bedside echo that we did on her. What we could observe from the bedside echo was that she had a dilated left atrium and the right atrium. The left atrium was poorly contractile. We could also see the thickened part of the interventricular septum here. And there was also increased refractileness on the echo. So this is a 53-year-old female with multi-system involvement and presence of constitutional symptoms. Clinically, she had a right heart failure, feature suggestive of a small fiber neuropathy, autonomic dysfunction, and a probable nephrotic syndrome. So differentials. Initially, we evaluated her along the lines of a nephrotic syndrome. Her blood showed LFT showed a low albumin of 1.61. CBC profile electrolytes creatinine was not significant, and the urine routine showed a 3 plus proteinuria, and spot protein creatinine ratio was 15.5, and the 24-hour protein was in the nephrotic range of 4,400. We also plan to go ahead with the renal biopsy to obtain the etiology for the nephrotic syndrome. And for the adult onset nephrotic syndrome, we consider the differentials of diabetes, amyloidosis, FSGS or a membranous nephropathy or an IgA nephropathy. However, her complements were normal, BBBS was negative, ANA was negative. She was not a diabetic, and her HbA1c was 5.4%. And then we went ahead to do an electrophoresis, which went on to show a M band in the gamma region. And her immunofixation electrophoresis showed a monoclonality for the lambda light chain and IgG. And spot benzone proteins were positive. And there was reversal of the kappa lambda chain ratio. There was increased lambda chains compared to the kappa chains. And we went ahead with a fat pad biopsy, which was positive for amyloid deposits, which was positive for Congo red stain and apple green birefringence. Her bone marrow biopsy finally went on to show a multiple myeloma, which are 40% foci of plasma cells with lambda chain restriction. Her echo, this is the formal echo that we obtained, which was showing features of a restrictive cardiomyopathy. Showed grade 3 diastolic dysfunction and other features to suggest a cardiac amyloidosis, which included a speckling of the myocardium, dilated left atrium with grade 3 diastolic dysfunction. Her baseline TROP-T and NT-proBNP are also elevated, TROP-T of 300 and NT-proBNP level of 33,000. So, coming to AL type of amyloidosis, amyloidosis is a clinical pathological disease process characterized by the deposition of amyloid fibrils in multiple body tissues. So, there are at least 36 different types of amyloidosis like AL, AA, we have AF, which is familial amyloidosis, we have ATTR, which stands for transthyretin, and dialysis related amyloidosis. What is important in systemic amyloidosis is the wide variety of presentations and the importance of correlating all physical findings to put together and arrive at a final diagnosis of amyloidosis. For a nephrologist, this can present as a proteinuria or a nephrotic syndrome, and for a neurologist, peripheral neuropathy or a carpal tunnel syndrome, and for the cardiologist, it can present as a restrictive cardiomyopathy. It is important to correlate all these findings to arrive at a final diagnosis. And once we arrive at a diagnosis of amyloidosis, it is important to find the type of amyloidosis and which are all the organs involved. The pathophysiology of amyloidosis, in AL type of amyloidosis, there is a particular clone of plasma cells which proliferate, and there is excess immunoglobulins which join with glycosaminoglycans and other amyloid related proteins to form amyloid deposits in multiple organs. This deposition causes organ dysfunction. In AL amyloidosis, the most common organs involved are the heart, which up to 80% of the time the heart is involved, and 60 to 70% of the time the kidney is involved. Other involvements can include the soft tissues, the liver, the peripheral nervous system, and the autonomic nervous system. And when to suspect amyloidosis in patients presenting with heart failure, and especially those presenting with a heart failure with a preserved ejection fraction, we also should look ahead for other features to suggest amyloidosis like foamy urine, hepatosplenomegaly, presence of macroglossia, presence of purpura, presence of autonomic dysfunction like orthostatic hypotension or intestinal dysmotility, and features of carpal tunnel syndrome, and patients with the constitutional and loss of appetite. The AHA recommends the following guidelines for patients presenting with heart failure with preserved ejection fraction to screen for an underlying amyloidosis: presence of intolerance to heart failure medications due to hypotension, presence of autonomic dysfunction, persistent low-level elevation of serum troponin, presence of carpal tunnel syndrome bilaterally, and when there is a discordance between the QRS voltage on the ECG and the LV thickness on the echo, and patients with unexplained heart blocks, and family history of cardiomyopathy. In our patient, we saw that QRS voltages were very small. There was poor RBA progression. However, there was LVH on the echo. ECG findings in cardiac amyloidosis. The most common findings associated with cardiac amyloidosis are low voltage in the limb leads, which was seen in at least 54% of the people, and unexplained AV block and a pseudo infarct pattern. We saw Q waves in the V1, V2, and V3, though patient did not have an MI, which is a pseudo infarct pattern seen in amyloidosis. Echo features to suggest an amyloidosis are presence of an LV thickness more than 1.2 centimeter without another explanation for the cause of the LVH, and the cherry on top appearance, which is nothing but the relative sparing of the apical segments of the ventricle compared to the longitudinal aspect. Presence of a normal or small LV cavity size and a speckling pattern on the myocardium, and presence of restrictive pattern or a diastolic dysfunction of the heart. Cardiac MRI usually shows a late subendocardial gadolinium enhancement. And there is also a role of radionuclide imaging in patients who have high degree of suspicion for an underlying cardiac amyloidosis. And we use the Peruggi grading to stage cardiac amyloidosis based on the radionuclide imaging. Grade 0, the intake is nil, and grade 1, the uptake of tracer is reduced when compared to the corresponding ribs. And grade 2, the uptake of the ventricle is comparable to the ribs, and grade 3, the uptake of the ventricle is more than the corresponding ribs. We use radionuclide imaging only when there is a high degree of underlying suspicion of amyloidosis, whereas the tests like electrophoresis and all this are not suggestive of a monoclonal protein. And this is the macroglossia we see with amyloidosis, and this is the panda eye sign which we see in amyloidosis. The most common organ involved is the heart, which is up to 80%. It's usually presents with a diastolic dysfunction, and the kidney can present as a nephrotic range proteinuria. The liver, it can present as a hepatomegaly. GI, it can present with altered bowel habits, malabsorption like features, and PNS, it can present as a distal sensory motor neuropathy. And in autonomic nerve system, it usually presents with orthostatic hypotension and GI disturbances like intestinal dysmotility. The renal staging of amyloidosis is based on the level of proteinuria and based on the EGFR values. And the most common staging system used for amyloidosis is the Mayo staging, which is which was last updated in 2012, which is based on the cardiac markers of troponin T, NT-proBNP, and the difference between the involved and uninvolved light chains. When 3 of them are below the threshold, it is stage 0, and when all 3 are elevated, it becomes stage 3. And this is the most common used system for staging because it strongly predicts survival, and it is the most common organ involved.
So, how many more slides we have?
And most common treatment, the current standard of care is the CyBody regimen. And that's a new update. We have a new RCT published in NEJM, which has compared a new monoclonal antibody which is directed against CD38, the daratumumab. The RCT compared daratumumab with standard of care versus the usual standard of care. And the results showed that there was a better chance of attaining a hematological response, a cardiac response, and a renal response at 6 months with daratumumab-based chemotherapy. So our final diagnosis for our patient was a systemic AL type of amyloidosis secondary to a monoclonal gammopathy, ejection fraction with grade 3 diastolic dysfunction with revised Mayo stage 3, a distal symmetric sensory motor axonal neuropathy, and an adult onset nephrotic syndrome. She was planned for a CyBody regimen for 6 cycles, and based on the response, she was planned for a autologous stem cell transplant. She has underwent 1 cycle of CyBody regimen so far. So take-home points, it is always important to correlate multi-system findings to arrive at a common diagnosis, and it is always important to suspect this diagnosis in a patient with heart failure, preserved ejection fraction, who doesn't have an obvious etiology, and patients with a nephrotic syndrome who have multi-system complaints. Thanks.
We'll move on to the last one.